Hello everyone. Today I am going to explain about drug interactions. What is a drug interaction? Drug interactions may be defined as a modification in the intensity and extent of pharmacological action of one drug by another drug. So one drug is getting influenced by another drug. Then interacting drugs are termed as precipitant and object drugs. Precipitant drug is the one which induces drug interaction, and an object drug is the one which is affected by the precipitant drug. Administration of more than two drugs can result in either synergistic or antagonistic action. In synergism, the drug action may be potentiated, that is, may produce an additive or supraadditive effect. But in antagonism, the presence of one drug may diminish or terminate the activity of another drug. Then coming to classification. So drug interactions can be broadly classified into three types. First classification, second classification and third classification. Under first classification, we can subdivide interactions into two types: beneficial interactions and adverse interactions. Based on clinical importance, drug interactions can be classified as first type, beneficial interactions. So not all drug interactions are adverse in nature. Some can be beneficial as well. Some of the interactions are intentional and they are called intentional drug interactions. Such interactions result in reduced drug toxicity, improved potency, reduced side effects and better outcome of drug therapy. So most of the drug interactions occurring inside the body may involve pharmacokinetic or pharmacodynamic mechanisms. Pharmacokinetic, that is ADME mechanisms, absorption, distribution, metabolism and elimination mechanisms, or pharmacodynamic mechanisms. So this is the combination of the drugs that produce beneficial effects and the resultant effect. Sulfonamide, when given in combination with sodium bicarbonate, there will be a decreased chance of crystalluria. So crystal formation in the urine will be reduced. Methenamine, given along with mandelic acid, there will be improved activity of both methenamine and mandelic acid. Penicillin plus probenecid, the resultant effect is enhanced penicillin activity. Rifampicin, when given along with isoniazid, leads to prevention of emergence of resistance. And ferrous sulfate, when given along with folic acid, can give a result of improved compliance. So patient medication adherence will be improved. Levodopa plus carbidopa, the resultant effect is enhanced therapeutic activity of levodopa. Aluminum hydroxide plus magnesium trisilicate, there will be decreased adverse effects. Sulfamethoxazole, when given along with trimethoprim, there will be synergistic action. So increased effect of sulfamethoxazole plus trimethoprim will be there. Then triple vaccine, diphtheria plus pertussis plus tetanus, when this combination is given, there will be ease of administration. That is why the vaccine is given as a combination. Gentamicin along with carbenicillin leads to enhanced activity against the microorganisms. Then second type is adverse interactions. Adverse interactions can be defined as the drug interactions where one drug opposes or adversely modifies pharmacological effect of another drug. So unlike beneficial interactions, in adverse interactions, the precipitant drug will be adversely affecting the object drug. This may result in failure of the prescribed drugs to produce the desired therapeutic action. This occurs when the prescriber prescribes a drug being unaware of other medications taken by the patient. So while taking patient medical history and medication history, it is important to note all the medications that are being taken by the patient prior hospitalization. If the prescriber is not aware of the other medications that are being taken by the patient before hospitalization, it can lead to prescribing a drug which interacts with the other drug. The drug interaction may take place either at pharmacokinetic or pharmacodynamic level, ADME level or pharmacodynamic level. So this is the combination of that drugs that interact adversely. Digitalis plus reserpine or chlorothiazide when given together results in cardiac arrhythmias, irregular heart rate. Then tolbutamide along with sulfasalazole or phenylbutazone leads to severe hypoglycemia. Then folic acid given with phenytoin leads to megaloblastic anemia. So phenytoin reduces the effect of folic acid. Since folic acid is used to treat megaloblastic anemia, the effect of folic acid is reduced and there will be worsening of megaloblastic anemia. Similarly, tolbutamide also, the action of tolbutamide is reduced by sulfasalazole or phenylbutazone, and it leads to, since tolbutamide is used in to treat diabetes, the reduced effect of tolbutamide leads to severe hypoglycemia. Then similar with the reserpine or chlorothiazide. Digitalis is used in cardiac arrhythmias. The effect of digitalis is being reduced by reserpine or chlorothiazide and it leads to cardiac arrhythmias. Then warfarin plus phenylbutazone or sulfenpyrazone. So phenylbutazone or sulfenpyrazone increases the effects of warfarin. So when warfarin effects increases, there will be increased risk of hemorrhage. Bleeding will be there. Neomycin plus succinylcholine, respiratory paralysis. Then methotrexate plus sulfonamides or salicylates leads to increased risk of methotrexate toxicity. So sulfonamides or salicylates increases the levels of methotrexate in the body. It leads to increased risk of methotrexate toxicity. Then levodopa plus pyridoxine, decreased therapeutic effect of levodopa. Then phenytoin plus isoniazid, phenytoin toxicity. Monoamine oxidase inhibitors plus tyramine leads to hypertensive crisis. Then sulfonamides plus methanamine leads to precipitation of sulfonamides causing crystalluria, crystals formation in the urine. Then coming to second classification, in second classification we can subdivide drug interactions into two types, pharmacokinetic drug interactions and pharmacodynamic drug interactions. But since B.Pharm 4th year 7th sem pharmacy practice subject covers only until pharmacokinetic drug interactions, I will be explaining in detail only about pharmacokinetic drug interactions. So pharmacokinetic drug interactions involve alteration or modification of ADME, absorption, distribution, metabolism and elimination of one drug due to the presence of another drug. So one drug is altering the ADME of another drug. The extent of such drug interactions is difficult to predict because of inter-individual variability. So since every individual has a different genetic makeup, they have different body mass index, different BMR, every body is different from other body. The extent of drug interactions, pharmacokinetic drug interactions cannot be predicted beforehand. The interactions may alter the drug concentration, which may either decrease its efficacy or cause toxicity. So in that, first subtype is absorption. In majority of cases, when the drug interactions occur in the GIT, this decreases the rate of drug absorption. So most of the cases what happens is rate of drug absorption of object drug will be decreased. But in some cases it will be increased. If there is no significant change in the extent or amount of drug absorption, then the rate of absorption is not of much importance for those drugs that are administered repeatedly. So when there is no influence of one drug on the other drug, the rate of absorption is not getting altered because of one drug, the other drug's rate of absorption is not getting altered, then it is okay to co-administer the drugs. We can administer two drugs repeatedly. However, delay in absorption may be significant when shorter half-life drugs are used or when quick attainment of plasma drug concentration is required. Example, analgesics, hypnotics. So, in some cases like analgesics, the patient is suffering with a lot of pain. The drug has to act immediately. So that drug cannot, there should not be any delay in absorption of the drug. And there should be quick attainment of plasma drug concentration so that they can show its effects. Similarly, hypnotics, when the patient is aggravated or aggressive or suffering from anxiety, we need to give hypnotics which act very fast. So there should not be any delay in absorption or any delay in drug distribution. So shorter half-life drugs should be used. So such drug interactions can be overcome by administering two drugs with a gap of at least 2 to 3 hours. So whenever we observe that two drugs are interacting and one drug is affecting the absorption of the other drug, we have to administer those two drugs with a gap of at least 2 to 3 hours. The drug interactions occurring due to alteration in the absorption of drugs may be due to the following reasons. Due to changes in gastrointestinal pH. Numerous drugs are either weak acids or weak bases and their extent of absorption is governed by the gastrointestinal pH. So non-ionized lipophilic drug is absorbed to a greater extent than the ionized hydrophilic form. So non-ionized drug is absorbed better than the ionized form. Example, absorption of neostigmine, an ionized drug, is very poor upon oral administration. Therefore, higher doses are required for obtaining therapeutic concentration. So, for the drug to act properly, show its action, since it is an ionized drug, neostigmine, we have to give higher doses because the drug's absorption is very poor. So lower pH favors the absorption of weakly acidic drugs. Example, salicylates, as these exist in non-ionized form. Thus, if the gastric pH is altered due to concomitant administration of antacids or proton pump inhibitors, then this adversely affects the absorption of other drugs. What do antacids or proton pump inhibitors like pantoprazole, what do? They increase the gastric pH. They reduce the acidic content of the stomach and they increase the gastric pH. So when they increase the gastric pH, they will alter the absorption of other drugs, other concomitantly given drugs, their absorption will be altered. Because lower the pH, there will be better absorption. If the pH is increased, absorption will be delayed. Then drug interactions involving changes in GI-pH. Object drug aspirin sulfonamides, precipitant drug antacids. There will be resultant effect is increased rate of dissolution, so enhanced absorption rate of object drugs. So aspirin and sulfonamides absorption rate will be increased when given along with antacids. Then tetracyclines ketoconazole when given along with antacids, there will be decreased rate and dissolution, so decreased bioavailability of tetracyclines and ketoconazole. Then ferrous sulfate when given along with Na2CO3 and CaCO3, there will be decreased dissolution and absorption of ferrous sulfate. Bisacodyl, which is enteric coated when given along with antacids, leads to irritation and vomiting due to disintegration of enteric coating in the stomach. So enteric coating of the bisacodyl tablet is getting disintegrated because of antacids. So it leads to irritation and vomiting. Then second mechanism is adsorption, chelation and complexation. When drugs are administered along with adsorbents like charcoal, kaolin or anion exchange resins, then their absorption is decreased as they get adsorbed onto the surface of adsorbents. So this charcoal, kaolin, anion exchange resins, they are adsorbents. So they adsorb this drug. Whatever drug is given along with them, they will be absorbing the drug and they will be binding to the drug, and they won't let the drug get bound to the receptor. So the drug cannot show its action, therapeutic action. Example, when propranolol is administered along with cholestyramine, then its absorption is decreased. So propranolol absorption will be decreased by cholestyramine. Similarly, certain drugs may react with other drugs and form chelates or complexes that are not readily absorbed. So certain drugs, what happens, they react with other drugs and they form a chelate or complex, which cannot bind to the receptor, and so the therapeutic action cannot be seen. Example, when tetracycline is administered along with antacids containing divalent or trivalent cations, they form insoluble complexes which reduces plasma levels of tetracyclines. These interactions can be prevented by maintaining a sufficient time gap of 2 to 3 hours between the administration of two drugs. The next mechanism is alteration in gastrointestinal motility. The main site of absorption of many drugs is the duodenum. Thus, any modification in the gastric emptying rate by the drugs can affect the absorption of other drugs. Drugs having anticholinergic action like phenothiazine can reduce the gastrointestinal motility and prolong the emptying of gastric contents. So anticholinergic action, phenothiazine has anticholinergic action, so it reduces the gastrointestinal motility. Since motility is reduced, the gastric contents in the gastrointestinal tract will take a long time to get emptied. This may increase or decrease the absorption of co-administered drugs. Example, when tricyclic antidepressants and dicameral are administered concomitantly, then the absorption of dicameral is increased due to prolongation of gastric emptying. Then drug interactions due to alteration in motility. So aspirin, diazepam, levodopa, paracetamol, lithium carbonate, when given along with metoclopramide, leads to increased absorption due to rapid gastric emptying. So absorption of aspirin, diazepam, levodopa, paracetamol, lithium carbonate will be increased due to rapid gastric emptying. Then lithium carbonate, levodopa, mexilatin given along with anticholinergics, tricyclic antidepressants, atropine, there will be decreased absorption rate due to delayed gastric emptying. Acetaminophen, nothing but paracetamol, when given along with propanthelene, leads to delayed absorption due to delayed gastric emptying. Then fourth mechanism is changes in gastrointestinal flora. Bacterial flora are present chiefly in the large intestine. Antibiotics destroy some of the intestinal flora, which increases the levels of certain undesirable species. So when we take antibiotics, the essential flora in the intestine are getting destroyed, which leads to increase of undesirable and unwanted species. Unwanted microorganisms levels are getting increased. Example, administration of antibiotics along with digoxin increases its risk of toxicity because the gut flora which inactivates digoxin are destroyed by the antibiotics. So gut flora actually inactivates the digoxin. Digoxin is a narrow therapeutic index drug, so gut flora will be inactivating digoxin. But when antibiotics are administered, since gut flora is getting destroyed, digoxin levels are getting increased in the body. So it leads to digoxin toxicity. Intestinal bacteria also hydrolyze the drug conjugate that is secreted into the bile. Certain antibiotics inhibit this process, thereby decreasing the drug reabsorption. Example, circulating levels of estrogens present in oral contraceptives are decreased by the antibiotics, leading to therapeutic failure. Then we have seen drug absorption. Then next, pharmacokinetic drug interactions. In that, first we have seen drug absorption. Then now we are seeing drug distribution. Most of the drug molecules after absorption bind to the plasma proteins, that is acidic drugs bind to albumin, while basic drugs bind to alpha 1 acid glycoproteins. So for the drug molecules to get distributed, they bind to the plasma proteins. Acidic drugs will be binding to albumin, basic drugs will be binding to alpha 1 acid glycoproteins. If there is another drug which has greater affinity towards plasma protein, it will compete with the former drug for the binding site and will cause its displacement. So we are co-administering two drugs, and second drug has a more affinity to the more binding capacity or affinity to the plasma protein. Then second drug will definitely, it will compete with the first drug and it will go and bind to the plasma protein at the binding site, and first drug will be displaced. First drug won't be able to bind to the plasma protein. This may result in toxicity due to increase in the free form of first drug. Example, warfarin is highly 98% plasma protein bound. If phenytoin is administered along with warfarin, then it competes with warfarin for plasma proteins and displaces it. Thus, there occurs an increase in the free form of warfarin, leading to its toxicity. Then drug interactions due to displacement of drugs from their plasma protein binding sites. So tolbutamide, when given along with sulfonamides, there will be increased hypoglycemia because tolbutamide won't be effective. Sorry, tolbutamide is an anti-diabetic, so it decreases the sugar levels in the body. But when there is displacement of tolbutamide, the tolbutamide levels in the body increases and it leads to increased hypoglycemia. Similarly, phenytoin, when given along with valproic acid, phenytoin will become a free drug in the body due to displacement by valproic acid, and phenytoin toxicity will be taking place. Warfarin salicylates, when given along with phenylbutazone, leads to increased hemorrhagic tendency. Because warfarin becomes free in the body, warfarin toxicity leads to bleeding and hemorrhage. Methotrexate sulfonamide given along with salicylic acid leads to methotrexate toxicity. Bilirubin along with sulfasoxazole leads to precipitation of kernicterus, leading to pseudojaundice. Then drug metabolism. So we have seen drug absorption, drug distribution, then coming to drug metabolism. Clinically important drug interactions involve alteration, that is either induction or inhibition of metabolism of one drug by another. So either one drug can induce the other drug or one drug can inhibit other drug. So first type is enzyme induction. Enzyme induction is a process where the synthesis of hepatic microsomal enzymes is increased in the presence of certain drugs such as barbiturates, phenytoin, rifampicin, carbamazepine, etc. Certain drugs like carbamazepine and barbiturates are capable of inducing their own mechanism. They are known as autoinducers and the process is known as autoinduction. So carbamazepine and barbiturates, certain drugs like that, what they do in the liver, they induce their own metabolism. So they are called as autoinducers and the process is called autoinduction. Induction of enzymes enhances the metabolism, leading to decreased pharmacological activity of the parent object drug. So because of enzyme induction, what happens? Metabolism increases. When there is increased metabolism, the pharmacological activity of the drug decreases. except in case of prodrugs where the metabolites are pharmacologically active. Drug interactions due to enzyme induction. Oral hypoglycemics, oral contraceptives. The precipitant drug is rifampicin. Corticosteroids, phenytoin, tolbutamide, oral contraceptives, coumarins when given along with barbiturates. Corticosteroids, cyclosporin, oral contraceptives when given along with phenytoin. Tolbutamide when given along with alcohol. Warfarin dicoumarol when given along with chloral hydrate. In all these examples, plasma levels of the object drugs decreases, leading to therapeutic failure due to enzyme induction. Then enzyme inhibition. There are some drugs that can oppose the activity of CYP450 enzymes, which inhibit the metabolism of concomitantly administered drug, leading to its accumulation. Enzyme inhibition is a dose-related process. The inhibition of metabolism of concomitantly administered drug starts as soon as sufficient inhibitor concentration in the liver is achieved. So for another drug to get to be inhibited, for two drugs are administered concomitantly. For the object drug to get inhibited, the precipitant drug should be sufficient. Sufficient concentration of the precipitant drug should be there in the liver. Then only the inhibition of metabolism of object drug takes place. Thus, the inhibitory action of shorter half-life drugs is seen within few days of concomitant administration of enzyme inhibitor, while for longer half-life drugs it takes a long time for the appearance of effects. Example, prescribing ritonavir enzyme inhibitor to a patient on sildenafil increases the concentration of sildenafil, thus increasing the risk of hypertension. Then drug interactions due to enzyme inhibition. Warfarin dicoumarol when given along with ciprofloxacin, clarithromycin leads to higher risk of hemorrhage. Then carbamazepine when given along with cimetidine leads to carbamazepine toxicity. Sildenafil when given along with ritonavir leads to enhanced risk of hypertension. Azathioprine when given along with allopurinol, increased risk levels of azathioprine may lead to toxicity. Oral hypoglycemics when given along with phenylbutazone, chloramphenicol leads to precipitation of severe hypoglycemia. Then we have seen about absorption, metabolism, distribution. Then fourth one is drug excretion. Excretion of majority of drugs takes place through urine or bile. Thus, there are chances of drug interactions if one of the concomitantly administered drug interferes with the urinary pH, glomerular rate and tubular secretion. So whenever one drug is interfering with urine pH or glomerular rate or tubular secretion, it leads to either decrease or increase in the therapeutic action of other drug. So under drug excretion, first type is alteration in blood flow to kidneys. Renal blood flow is controlled to a limited extent by the prostaglandins, which are renal vasodilators. So what prostaglandins do is they dilate the blood vessels that supply blood to the kidneys. Hence, if any drug interacts with prostaglandin synthesis, there would be alteration in excretion of other drugs. Example, if indomethacin, which is an inhibitor of prostaglandin synthesis, is given to a patient on lithium carbonate, then there would be inhibition of excretion of lithium leading to toxicity. Lithium is also a narrow therapeutic index drug. Then alteration of urine pH. When the urinary pH is modified, the action of the drug excreted either in active or unchanged form is altered. This may cause either excretion or reabsorption of the therapeutically active drugs. The extent to which the drug is present in non-ionized or ionized form influences its reabsorption. Only non-ionized molecules are reabsorbed. The effectiveness of weakly acidic drugs is reduced in alkaline urine pKa 3 to 7.5 because being present as ionized molecules, these are not reabsorbed and readily excreted. However, changes in urinary pH does not affect strong acids and bases as they are ionized to a larger extent over the physiological range of urinary pH. So, normal range of urinary pH is enough for strong acids and bases to get ionized. So, they will be easily excreted. Moreover, the process of acidifying or alkalinizing the urine is used as a means for enhancing the drug excretion during poisoning. Example, salicylate and amphetamine. So, for removing the excess drug from the body during toxicity and during poisoning, they will be using this method, and they will be either acidifying the urine or alkalinizing the urine so that they can increase the elimination of the drug. Drug interactions due to alteration in urinary pH. Methenamine given along with mandelic acid leads to resultant effect is enhances the drug's activity by favoring the conversion of methenamine to active metabolite formaldehyde. Then sulfonamides given along with methenamine leads to precipitation of sulfonamides leading to crystallization. So in urine there will be crystalluria. Then salicylates given along with acidifying agents leads to higher plasma concentrations of salicylates leading to toxicity. Sulfadiazine given along with sodium bicarbonate leads to enhanced solubility of sulfadiazine, so reducing the chances of crystalluria. This is a beneficiary interaction. So beneficial interaction, sulfadiazine given along with sodium bicarbonate, there will be reduced chances of crystalluria. It is a beneficial interaction. Streptomycin, ranamycin, erythromycin when given along with alkaline agents leads to increased effectiveness from permitting use of low dosage, hence reduces toxicity. This is also an example of beneficial interaction. So third mechanism is competition for renal tubular excretion. When two drugs utilize the same active transport mechanism for excretion, then the drug with higher affinity for the excretion mechanism gets excreted first. So two drugs are competing with each other for getting excreted at the site of excretion. Such a condition can be employed for therapeutic success. Example, probenecid may be administered concomitantly with penicillin because it competes with penicillin for renal secretion and gets excreted first due to higher affinity. Since probenecid has higher affinity, it will be getting excreted first. This leads to increased systemic levels of penicillin, resulting in its enhanced therapeutic activity. So we can use this method to improve the therapeutic activity of one drug by co-administering two drugs. But the other drug should have higher affinity to the excretion. Then drug interactions due to competition for renal tubular secretion. Salicylates given along with furosemide, there will be increased risk of salicylate toxicity due to its retention. Then methotrexate given along with NSAIDs, increased risk of methotrexate toxicity. Then digoxin when given along with quinidine, there will be higher levels of digoxin causing toxicity. Then biliary excretion. Fourth mechanism is biliary excretion. Apart from urine, many drugs are excreted through biliary excretion from the bile, either in conjugated or unchanged form. There occurs reabsorption of certain conjugates that undergo metabolism by gut flora to give their corresponding parent compounds, thus extending their stay in the body. However, gut flora may decrease upon concomitant use of antibacterial drugs which inhibit the recycling of process leading to quick loss of drug from the body. Example, when oral contraceptives are concomitantly administered with antibiotics, their enterohepatic circulation is reduced, resulting in therapeutic failure. So that is about drug interactions. There is a third classification of drug interactions also, which includes drug-drug interactions, drug-food interactions, drug-alcohol interactions, etc. But that is not covered under the syllabus of B.Pharm 4th year 7th sem pharmacy practice. So I have only explained till beneficial interactions, adverse interactions, and pharmacokinetic interactions. Pharmacodynamic interactions also I have not explained in this PowerPoint. So next topic is methods for detecting drug interactions. Role of pharmacist in the detecting and preventing drug interactions. So if the pharmacist follows proper instructions and precautions regarding the medication, then most of the drug interactions are predictable and can easily be prevented. Patient counseling plays an important role in the prevention of drug interactions. A pharmacist counsels the patient regarding the safe use of the drugs. The complete medication profile should be reviewed thoroughly by the pharmacist before dispensing the medicines to the patient. If the pharmacist does not get the essential information from the patient medication profile, then he or she should ask the patient various questions in order to get complete information. He has to review the drug profile record. So only if we know the past medical history, medication history clearly about the patient, we can assess whether there are any drug interactions in the current prescription and the past medication that they are using. So complete patient information should be gathered by the pharmacist before dispensing, and even while patient counseling they have to check whether there are any drug interactions, and they have to inform it to the patient. Then patient counseling. The pharmacist counsels the patient regarding the following aspects: to take the medicines prescribed by the physician only and not go for self-medication. So the pharmacist should be advising the patient not to go for OTC medication, over the counter medication or self-medication. Medication should be taken as directed, that is dose, frequency and route of administration should be correct to achieve the desired therapeutic effect. So pharmacist should be explaining the correct dose and the frequency, whether they should take the tablet or capsule or syrup or whatever in the morning or afternoon or night, and also the route of administration, whether they should take it orally or as intravenous route or intramuscular route, subcutaneously, or everything should be explained to the patient. Proper instructions to be followed while taking the medicines, that is time of administration, and to advise the patient regarding drug interactions or other drug related problems the patient may encounter. Pharmacist should counsel the patient regarding drug-food interactions, such as to avoid milk and milk products with tetracyclines, to avoid tyramine-rich foods with monoamine oxidase inhibitors, and to take sugar-free diet during anti-diabetic therapy. To avoid consumption of alcohol during therapy. To counsel the patient to take a healthy and balanced diet. Then methods. A pharmacist can detect and manage the drug interactions by the following methods. First is identification of patient risk factors. During patient counseling, various factors like age, sex, medication history, habits like smoking, alcohol consumption, etc. should be taken into consideration by the pharmacist. Then second step is taking consideration of proper drug history and patient medication history. Unawareness of prescription and non-prescription drugs causes various drug interactions. Hence, pharmacist can obtain the complete current prescription and non-prescription medication records of a patient and also his dietary habits. Since there are drug-food interactions also, drug-alcohol interactions also, they should be taking dietary habits as well as smoking and alcoholic history of the patient. Having thorough knowledge on drug actions. The pharmacist must have thorough knowledge on therapeutic effects, properties, and dosages of various drugs in order to recognize and manage the drug interactions. So, if the pharmacist has proper knowledge on drug interactions, proper dosage, they can advise the patient. If at all they find any drug interaction in the prescription, they can advise the patient to reduce the dose or increase the dose of one drug or the other drug, or they can advise for 2 to 3 hours gap in the while taking the medication. They can change the frequency. They can change the frequency of administration of drug. If the drug is being taken in the morning, they can advise to take in the afternoon. So that is how the pharmacist can prevent the recognize and prevent the drug interactions. Then fourth step is considering alternative therapy. If the pharmacist recognizes that two drugs interacting with each other as prescribed by the physician, then with the help of his therapeutic drug monitoring knowledge, he can alter and adjust the dose of these drugs, or else he can replace these drugs with alternative drugs possessing the same therapeutic activity. So he can suggest for alternative drug with the same therapeutic activity, or he can change the dose of the drugs, or he can adjust the frequency frequency of administration, or he can change the route of administration. Avoiding complex multiple drug therapy. If possible, usage of complex multiple drug therapy can be minimized if possible. In this case, dosage regimen can be adjusted to reduce the risk of drug interactions. So when there is a multiple drug therapies, there is polypharmacy in the patient medication profile. The pharmacist can identify that, and they can reduce the dosage regimen. They can avoid giving unnecessary drugs, and they can educate the patient. And sixth step is patient education. The pharmacist must educate the patient about their medication, like route, time of administration, dosage, precautions, etc., in order to improve patient compliance. He must encourage the patient to ask various questions regarding his medication, and also to report any drug related problems. So while counseling, the pharmacist should prior inform to the patient regarding the possible side effects. So if you take this drug, you may experience certain side effects. So when you see certain side effects, when you observe them, you have to consult the physician. So the patient should be educated by the pharmacist. Then therapeutic drug monitoring. The pharmacist should monitor the drug therapy in case of risk of drug interactions, adverse drug reactions, and non-compliance. Non-compliance is the patient not taking the drug at the right time that is prescribed. If the physician asks the patient to take the drug at morning, if the patient is forgetting and taking the drug at night, that is also non-compliance. And if the patient is completely forgetting to take the drug, that is also non-compliance. And if the patient is wantedly avoiding the drug, that also comes under non-compliance. So it is non-medication adherence. So under therapeutic drug monitoring, the pharmacist should monitor for any kind of drug interactions, adverse drug reactions, and also non-compliance, because non-compliance can lead to therapeutic failure. Pharmacists should maintain a complete past and present medication history of the patient, and should monitor the drug therapy in order to recognize and prevent drug interactions. If any drug interactions are noticed by the pharmacist, then it should be recorded immediately and reported to the Pharmacy and Therapeutics Committee. After case study, necessary steps and precautions can be taken by the PTC to prevent further drug interactions. Thank you for listening. Please like, share, comment, and subscribe to my channel. Press the bell icon for more notifications.